Thank you very much, and good evening, everybody. Thank you for the invitation to speak. And as Rena says, I am a consultant in Old Age Psychiatry, and I work in St. John of God Hospital currently. I have moved around a little bit through the HSE, and currently I'm in St. John of God Hospital. I work with older people only, and that's my specialty for the last 20 years. I hate to say that because it sounds like a very long time, but it is 20 years since I took up my first consultant post in this specialty. So thank you all very much for coming out tonight. The weather is dreadful, the traffic is awful. I spent an hour and 10 minutes coming over from Stillorgan, which normally should take half an hour or so. And of course it's Christmas as well, so I'm not surprised that maybe we don't have a full hall. But I'm not going to mention how many are here because nobody else knows except us online. So I was asked to speak by Breed O'Mara from Aware, and we suggested a topic of, is it depression or dementia? I can honestly say in my career, we see with older people two groups of people mainly, the people with depression and the people with dementia. We do see people with delirium, we see people with psychosis, all sorts of mental illnesses, but these are two of the most common. And it can be tricky enough to separate out at times. So what am I going to talk about? I'm going to talk about depression in older people. How common is it? And how is it different in older people as compared with younger people, or is it different? I'm going to talk a little bit about, I'll talk about dementia, the various types of dementia that there are, and how common that is within the population. Of course, we all know that the population is getting older, and particularly in the very old, so we have a higher prevalence of dementia than we would have had many years ago. There are various types of dementia, and people often say to me, is it Alzheimer's or is it dementia? And so I'll clarify a little bit around the types of dementia, what the difference is, and why do we want to diagnose different dementias, and why is it important? The types of presentation of people, and then looking at the comparison between depression and dementia. And obviously, we can have coexistence of both. And depression is very common in people with dementia for understandable reasons, particularly early in the illness, but also later on in a person with dementia. And then just a little bit about management, and that's then we'll have questions and answers after that, hopefully. So as I said, depression is very common in older people. It's often missed and it's often undertreated. When I trained in the UK, the Psychiatry of Old Age Services developed there in about the 1970s, when did I go, 80s, something like that. And up until that, I think people felt that an older person who was sitting quietly in the corner, they didn't really pay much attention, maybe, granny's getting a bit confused or a bit senile, as they call it, but didn't really pay much attention. But gradually people realized that in fact older people suffer from all the mental illnesses that younger people do, in addition to organic disorders such as dementia. So the services were set up and the specialty was developed in the UK, and gradually it was developed here too, with the first Psychiatry of Old Age service being set up in 1989 or 1990, something like that. So, just to illustrate the point at the beginning as to what I'm talking about and why it's difficult to tell, this is obviously not a real case. It's a mixture of a number of cases or symptoms, shall we say. So reading that history, you could go either way. You could say this man is confused, he may have dementia, or maybe he's depressed. He's got a very short history, he's keeping to himself, he's lost appetite, lost weight because of a poor appetite, not really looking after himself, living alone, and presents with a chest infection and confusion. So I think looking at that, I wouldn't be able to say, and I deal with this day and daily and multiple times a day. It doesn't give us enough information, but you can see how confusing it might be, that you might go for one diagnosis rather than another. So we'll move on to talk about depression first. As I said, I'll talk about depression in older people. And it is common. It's about 10 to 15% of older people have depressive symptoms. They may not have a depressive illness, but they may have depressive symptoms. About 3% have a depressive illness, and it's particularly, and there's a higher rate in those in institutional care, those in long-term care, in nursing homes, supported living settings, or in general hospitals. Again, in general hospitals, very common in association with medical illness, and again, the older person is quiet, in bed, maybe socially withdrawn, not eating, not really conversing, and it could be missed because it could be put down to being due to the medical illness that's there, but often there's a comorbidity, there's both the medical illness and the depression. So it's common, it's underdiagnosed, as the example I was just talking about, but it's more importantly, it's a treatable condition. And I think that's the key, that it is a treatable condition, and that many times in my career, when I've been seeing people, older people with depression, people say, but look, she's old, why not just, it's okay, just leave it. You don't need to be terribly active about it, active treatment-wise. But it is treatable, and people do get better. I have one particular lady who sticks in my mind. She was a lady with severe depression, and I wanted to treat her. She wasn't eating, she wasn't drinking, she was particularly unwell. I wanted to give her ECT, and the family were very concerned about this. Naturally, mother was about 85, I think, at the time. But in fact, we talked about it, we discussed the pros and cons, and eventually the lady was treated, and she did go home, and she did get better, and she did enjoy a much better quality of life. And that lady always sticks in my mind. When you see somebody who's very depressed, it's really important to actively treat. So I found this quote, and I think I'm not going to read it out because I'm sure you can read it from there. It is a good description of what depression feels like. So, and when you ask somebody, are they depressed, particularly older people, they say, well, I don't know what depression is. I've never been depressed, for example. And so you have to investigate a little bit further and see what other associated symptoms there are and try and find out what exactly they're feeling. So in order to diagnose depression, what do you need? Well, at this you will be, if you've seen the diagnostic criteria for depression, it's exactly the same in older people as it is in younger people. So 5 or more symptoms over a period of 2 weeks, and it must include either depressed mood or loss of interest or pleasure. And the loss of pleasure or the loss of enjoyment is something that we see very regularly in older people. That's often what the presenting complaint is. Somebody will come in to see me and I will say, and what's the problem? And they will say, I can't enjoy anything. Everything is gone. I can't enjoy my life. And then the loss of interest will go with that. So what symptoms are there? As well as the depressed mood and loss of interest or pleasure, we have loss of appetite with weight loss. You can have increased appetite and weight gain, but it's less common. You can have slowing of thought or movement, loss of energy, feelings of worthlessness or guilt, which again can be more prominent in older people, and recurrent thoughts of death or suicidal ideation. Again, there's another quote I found, which I thought was described what it's like to be depressed, that feeling of emptiness and not being able to talk, not to have interest or pleasure in anything. So the other thing, as well as the symptoms, it has to have there has to be significant distress or concern about how a person, if it's not distressing them, then maybe it's not depression. But there should be significant distress or impairment of social or occupational functioning. So people, commonly older people, are not working outside the home, but some do. But it's commonly social functioning that we see, that loss of and withdrawing from interests that they might have, which might be anything from playing golf to playing bridge, singing in a choir, reading, whatever interests they may have. And in older people, we know that the research would show, and the evidence is there, that there's significant morbidity associated with severe depression. So people can get physically unwell because they already may have medical illnesses in addition to depression, so they may become medically more unwell with depression. There may be cardiac disease, there may be diabetes, and it may be partly to do with the fact that they maybe don't mind themselves as much as they would have if they weren't depressed. They maybe don't comply with medication that they're on for other illnesses. But it's certainly something that we would watch out for. And as an old age psychiatrist, I see many people who have medical illnesses in addition. And clearly, just like younger people, it is a risk factor for suicide. And there are two peaks for suicide. One is younger people, and the other peak is older people. And I was just listening on the radio on my way out here, when I was the hour and 10 minutes in the car. Joan Freeman was talking about teenagers, and she was talking about teenage girls, and apparently Ireland is now the highest rate for suicide in teenage girls in Europe, which I wasn't aware of, which is absolutely shocking, to say the least. So, what differences in presentation do we have for older people, or what's different about depression in this age group? Well, firstly, as I said, we have the overlap of physical and somatic symptoms, and the comorbidities I mentioned. So you have people who may have chronic pain from arthritis, for example, chronic pain from neuralgia of one description or another. One could have heart failure and a feeling of fatigue, which would be very much a feeling that would go along with depression. So you're trying to tease out how much of it is to do with the heart failure, how much of it is to do with depression, and to make sure that the medical side is optimized. So they're on the right medication for their heart, so it's functioning at its optimum, as well as treating using medication. And of course, the medication for depression can interact with all sorts of other medications. So that is something that, as working with older people, we have to be aware of. And I'm constantly looking at lists of medication, making sure there's no interactions, making sure that one won't interact with the other and cause more adverse symptoms, or, for example, falls, which would be something that we would be very cautious around for older people. COPD, people who have chronic obstructive airways disease, chronic obstructive pulmonary disease, may feelings of breathlessness, and again fatigue and anxiety around not being able to breathe properly. That can all interfere and precipitate a depressive illness, and again has to be managed. Both conditions have to be managed. Parkinson's disease, it's a very common illness, and almost not quite goes hand in hand, but depression is very common in Parkinson's disease, and that has to be carefully managed both with the neurologist or GP and psychiatrist for older people. Again, some of the medications can worsen Parkinson's, so we have to be aware of that. So it's a constant juggling. And older people are more sensitive to medication, so they are more sensitive to the side effects of medication because of the absorption, because of the metabolism that changes as we get older. So we have to be cautious with dose increases and what medications we use. There may be differences in an expression of sadness. I mentioned earlier that when somebody comes to me and you say, well, why have you come to see me today? They may not necessarily describe a feeling of sadness. It may be that there's a sleep problem. It may be this loss of enjoyment I talked about. And you need to investigate a little bit more. It's not always predominant. It's not always the predominant symptom. So sometimes we get physical complaints disproportionate to the known pathology. So people are very anxious about themselves and can be very worried that pain, for example, is much worse than normal, much worse, and we have to be cautious. We have to investigate the pain to make sure that there's not an organic cause, that we're not missing anything, but at the same time it may be a symptom that becomes more exaggerated because of the mood disturbance. So we have to balance that act as well. Again, if somebody has anxiety features, and they've never had anxiety before in their lives, say, I get, an 80-year-old lady who comes for the first time, never seen a psychiatrist before, no family history, never had any problems, but presents with anxiety, I would certainly be screening them for depression to see if that's something that needs to be treated. Deliberate self-harm, I'm sure you'll be aware of the rates of deliberate self-harm in younger people, but in older people, it would be a red flag for depression. It's not something that older people would engage in unless there was a significant problem. You can get depression superimposed on dementia, and I'll talk about that in a few minutes. Late onset alcohol dependency, again, could be something that might be secondary to depressive illness. So somebody who's never had an alcohol problem before slips into drinking more and more because their mood is low, and then you have that awful cycle of the more you drink, the more depressed you get, the more you drink, and so on, and it can be very difficult. Behavioural problems, and that really, I'm not sure that I like the phrase, but anyway, I should have changed it, but really something like agitation, pacing around, not able to settle, and not sleeping at all, maybe up all night, very distressed in themselves. That can be typical in an agitated depression. And there can be an accentuation of premorbid personality traits in people, in older people as well. So that's really the presentation of depression. I didn't talk about the psychotic features. I'm just realizing while I'm talking here, and one can get in a severe depressive episode, there can be significant psychotic symptoms if you're somebody who's very depressed. So they can get delusions or fixed false beliefs about being bad person would be the typical one in older people. Being a bad person, being very guilty about something that has never happened in the past. Or something like somebody said to me recently, I just don't think I was good enough. And I said, well, why were you not good enough? But couldn't come up with anything other. Maybe I should have phoned my friends more. And that's very negative thinking when there's no evidence to the contrary. I'm not saying that's a delusion, but it is nihilistic thinking, shall we say, or negative thinking. You can get auditory hallucinations in somebody who's severe depression. Sometimes voices which are very critical, or saying, sometimes it could be damning somebody to hell for all time. That would be a very depressive hallucination to get. So those symptoms can happen, and if you've got somebody with severe depression, an older person with severe depression, and those features, then that really needs probably to be hospitalized and to be managed carefully to improve the mood. As the mood improves, the psychotic symptoms improve, and a person gets better. So just to move on to dementia. So what is dementia? As I said earlier, and I did look back through, I'm not sure whether this lecture series has covered dementia or not before, so forgive me if you're familiar with it, but dementia is the umbrella term for all dementias. Some years ago I found a picture of an umbrella, somebody describing dementia, And the umbrella is in various sections. So if you divide it into sections, Alzheimer's is responsible for 2/3 of the umbrella. So Alzheimer's is the most common cause of dementia, and so there are other ones as well, which I'll go through in a few minutes. So dementia is the umbrella term, and then you've got various different types. And there are various reasons why we need to know what type it is, because it makes a difference as to what we do in terms of our treatment, which is not really the purpose for this lecture, but it is something that we as psychiatrists would want to know, or as doctors even. So what is it? It's a clinical syndrome, but it is a pathological disease of the brain. So there are brain changes. There are pathological changes in the brain, and they differ between the various types of dementia that we have. So sometimes it might be in Alzheimer's, might be plaques and tangles, as they so-called, an accumulation of abnormal protein, and then tangles, neurofibrillary tangles. Or it might be mini strokes in the case of vascular dementia. So it's there's a pathological changes within the brain. It is a chronic disease, and it is a progressive disease. We always have to check to make sure that we haven't missed a reversible cause of dementia. But if one is diagnosed with dementia, it is chronic and it is progressive. That's not to say that there aren't things that we can do to make things better, to slow the illness down, and to improve quality of life. We can. So what does it do? When people think of dementia, they think of memory. So what's the problem? Loss of memory. But it not only affects memory, it affects thinking, it affects orientation, knowing where you are, what you're doing, the time of day, the month, the year, and so on. Comprehension, it affects understanding. It affects calculation, being able to deal with money, for example, and knowing how to manage money and how to manage shopping. It affects learning capacity, because the short-term memory is poor. It's very hard to learn if you can't remember from one place, one minute to the next. It causes difficulties in language, so people not being able to find the correct words for simple objects even, or for more complex areas. So they may not be able to understand what people are saying, and they may not be able to express properly. So you've got both sides, and this is further along in the illness. And it also affects judgment, so people aren't able to plan, coordinate, look after their lives in a way that they would have done before. And in addition to that, you get a deterioration in emotional control. So maybe somebody is more likely to get angry where they mightn't have got angry before. They might be more likely to cry where they didn't cry before, so becoming more labile in mood. They may not behave in a more socially as we would have always done. They may be more disinhibited socially than normal. And they may be very poorly motivated, and apathy is a very significant, a very frequent, common symptom in people with dementia. I just found this on Google Images. I thought it was quite good, given our health service and the state that it's in. So the various types of dementia. So these are the top four types of dementia. So as I mentioned, Alzheimer's dementia is responsible for 60% of those for people with dementia. So 60% of dementias are Alzheimer's. Vascular dementia is responsible for about 1/5, and vascular dementia is caused by mini strokes. So any risk factor for stroke is a risk factor for vascular dementia. So what are the risk factors for stroke? Well, smoking, alcohol, weight, exercise, diabetes, blood pressure. So all of those things, the things that we all mind, cholesterol, that to optimize our health, or should do anyway, are risk factors for stroke, and therefore a risk factor for vascular dementia. So when you think of a stroke, you think of a weakness down one side, but if you get the stroke happens in the part of your brain that is responsible for your memory, then you can get memory problems. So essentially that's the underlying pathology. So about a fifth of people. And then there's a crossover between Alzheimer's and vascular. You can get a mixture between the two. Lewy body dementia is less common, and it's caused by, the pathology is actually called Lewy bodies, and that's why it's named Lewy body dementia, because they're abnormal bodies within the cells in the brain. So what does it cause? Well, I'll go through it in a minute, but it's a different progression and a different presentation to the other two. Frontotemporal dementia, again, is less common again, and it affects mainly the frontal and the temporal sides of the brain. And again, I'll talk about that in a little bit more. And then there are many more. So there are many more causes of dementia, but these are the ones that are the most commonly seen. So Alzheimer's dementia is it's gradual in onset. It's the one where generally the short-term memory starts first, the loss of short-term memory rather, gradual onset, and a gradual decline in memory and function. And function, that would be how a person is managing their daily lives, their activities of daily living, looking after themselves, doing the shopping, looking after medication, looking after their bank accounts, looking after the house, and so on. So it's not only about short-term memory. You could have short-term memory loss, which wouldn't mean that one has dementia. One must have a loss of function as well. There's an absence of other causes. I mentioned earlier, we have to be sure that we're not missing something else, so there isn't some other cause. So what else might we be thinking of? We might be thinking of thyroid, we might be thinking of vitamin deficiencies, we might be thinking of diabetes or a medical illness that is causing this. So we have to investigate all of that to make sure that we're not missing something. The illness must be there for about 6 months before we would diagnose it. So if somebody just has this for the last week, that would be way too short to come up with a diagnosis of dementia. You're talking about 6 months at least before you could make the diagnosis. And often I will ask people, when did you first notice, commonly, husband, wife, mother, father, when did you first notice that the memory was poor? And it starts off, maybe 6 months, there's somebody with dementia now, maybe 6 months, and then somebody else in the room will say, no, maybe it was about a year. Oh, do you remember 2 years ago? And it generally is quite an insidious start, and it goes very, very gradually. But when you think back, it usually, by the time they present to somebody like me, it's been going on for quite some time. And there should be no clouding of consciousness. So clouding of consciousness is when you have poor attention, disorientation, which is due to usually a medical condition. So if you have an infection, a delirium, that's what the clouding of consciousness is. There are many other causes of delirium other than infection, but a delirium is an acute confusional state, a short-lasting state that is caused by medical issues or medication, perhaps. Vascular dementia then is the one that is caused by mini strokes. Cerebrovascular disease, so you can see there may be focal signs, there may be signs of having a stroke as well as seeing the dementia. So you may get a weakness on one side, you may get other signs that go with having the vascular dementia. In those that are caused by stroke, it's usually the onset of dementia is within 3 months of a stroke. There's usually an abrupt deterioration. So Alzheimer's is said to have a slow progression, gradual but significant, but progressive deterioration. Vascular dementia is said to have a stepwise progression. So you go along for a while, there's a drop-off in function, go along for a while, another drop-off in cognition. So it's a stepwise progression, as this slide says. In addition, you might get some walking problems, gait disturbance, mobility issues, falls, not walking as well as previously. And there may also be personality and mood changes, which I'll come back to. So the Lewy body dementia is the one I mentioned that is so called because of the presence of Lewy bodies in the cells. And it is different to the other two because it doesn't usually present with significant short-term memory loss. It usually affects with fluctuating cognitive impairment, so it fluctuates within a day. The morning might be good, the afternoon bad, the evening good again, or vice versa. It fluctuates throughout the day. And people who are caring for people with Lewy body will see that very frequently, that it moves from being quite steady, quite stable for a while, for some hours, and then there'll be periods of hours when there's difficulties. So what are the presenting features? Well, visual hallucinations are very common. A visual hallucination is seeing things that aren't really there, in effect. So you might see, I've had people who have seen things like children. There'll be children running around the house. I had one lady and she was convinced, absolutely convinced, that there was a man sitting on her wardrobe. He wasn't bothering her, she was quite happy, but it was certainly, there was nobody there. But she had Lewy body dementia, as it turned out. You can certainly get paranoid symptoms as a result of that, because then people think, well, if there's somebody in my house, they must be taking my things or they must be doing something. So it's sort of a secondary interpretation of what's happening. And then you can have this exaggerated response to medication. So often we will use a certain type of medication to help with the hallucinations and to settle distress if it's present. But if it's Lewy body dementia, they can have a very significant adverse response to that medication, so we have to be very cautious. So hence that's one reason for knowing what the diagnosis is, so you know what you can give, what treatment you can give, and what the best options are in terms of medication. Frontotemporal dementia then is the last one I'm going to mention as a type of dementia. As I said, there are many more, but I'm not going to go through any more. But frontotemporal dementia affects the frontal part of our brain and the temporal part, which is responsible for language and memory. Usually insidious onset and slow progression. It's primarily characterized by behavioural difficulties. So our frontal lobes are responsible for, your planning, control, judgment, the fact that you would be socially aware, you wouldn't be disinhibited. So the obvious example is as people drink more, they become more disinhibited because their frontal lobes get released. And equally with frontotemporal dementia, disinhibition is a significant feature of this condition. Mental rigidity, not being able to see the grey aspects of life. They're very black and white in terms of how they interpret what's going on around them. An early loss of personal and social awareness. So again, this disinhibited behaviour. It can be hypochondriasis, it can be worry a lot about physical symptoms that aren't really that aren't really a problem. Apathy can be a significant concern, as it can in the other types of dementia, particularly Alzheimer's. Apathy, lack of motivation, not wanting to get out of bed, can't be bothered getting out of bed, not really interested in doing the things they used to do. And hence we have the crossover with depression. So is it depression or is it dementia? You can get language impairment with frontotemporal dementia because it affects the temporal lobes, which is responsible for language production. But usually they're much better orientated. So people with Alzheimer's are much less likely to be orientated in terms of time and place. In frontotemporal, they can be quite well orientated. So there's quite a lot of differences between the various types of dementia and then the various treatments that we would use. So what do we see with dementia? I've mentioned the various types of dementia, but in general, these are we can divide the symptoms into cognitive symptoms and non-cognitive symptoms and neurological symptoms. So the cognitive symptoms are, memory, language. So we can have short-term memory loss, which is usually the presenting feature in something like Alzheimer's dementia or vascular dementia. But the long-term memory is preserved until later in the disease. So people will remember, their own childhood homes. They will remember early on in marriage, early on in their family life, but maybe it's the more recent events that are particularly early in the illness. It's the more recent memory that goes. What's happened yesterday? Who visited? What was on the news, for example. But the long-term memory is better preserved until later in the disease. Unable to learn new material, and that's one of the tests we do to check how people are retaining information. We ask them to learn something and come back and ask them to repeat it after a few minutes to see can they keep material in their minds. You can get language dysfunction, as I mentioned. You can get word-finding difficulties, and you can also get poor understanding. You get repetition. Repetition is one of the features that can happen early in dementia, and it's often the ones that carers find very difficult to cope with, where the repetitive nature of questionings and where are we going today? 5 minutes later, and where are we going today? And so roll on 3 hours later, and we're still umpteen times later, where are we going today? Or what day is it, for example? Or could be anything. But it can be very hard to manage if you're living with somebody like that, and it's to try and help people to understand that this is not deliberate. And often I'm asked, they're doing it deliberately to annoy me. They do remember, they know, of course they know, but it's not. It's the fact that they're not able to remember, and that can often be helpful. Even understanding that in itself can be helpful, that it's an illness. Poor visuospatial functions, so not being able to coordinate and put things together. One of the common things we ask people to do is to draw a clock. So we ask people to draw a clock, put in the numbers and put in the hands at a particular time. And it's very sensitive to change. So we can look at visuospatial function. I'm often thinking now, but I won't be around, I guess. I certainly won't be working. But in years to come, our young people won't be able to draw a clock because there won't be any clocks because they all use their phones. So it's going to be, it'll be interesting to see how that pans out in the future. So we can have non-cognitive symptoms that occur with dementia as well. So depression is common. It's very common. If you're losing your memory, it's very difficult. It's a very stressful situation and certainly can precipitate a depressive episode. Mania would be rare. Very rare to see somebody with mania. I have seen it, but it would be unusual in people with dementia. Delusions, persecutory delusions, these are very common in people because the interpretation of losing things, which is quite common because of short-term memory loss, you put something down, you can't find it, well, you must have moved it. Actually, you took it. You're taking things from me, and that paranoia can be distressing for people. You can get visual hallucinations and hearing auditory hallucinations, particularly in Lewy body, but you can get it late in the other illnesses as well. And sometimes misidentifications, misidentifying people or themselves, again later on in the illness. You can get changes in behaviour as part of the non-cognitive symptoms of dementia, and I suppose that's where I have spent a lot of my time dealing with people who have dementia and these behavioural changes. And it's very common in people with dementia to have this at one point or another. So the reduced sleep would be the most common one that I would see. But you can get irritability, you can get agitation, you can get apathy, all sorts of complications that go with dementia. And again, if you look at this, you would be forgiven for thinking, well, a lot of that you would get with depression. So is it depression, is it dementia, or is it a combination of both? So you always have to I have to keep my mind open to the possibility of what it is and what needs to be done to make things better. Neurological symptoms, and a lot of them I've gone through already, but that's a list of what can happen. Language, failure to recognize things, impaired coordination, so-called dressing dyspraxia. So people who can't get I don't have any buttons, but can't get the buttons on right, or get the jumper goes on backwards, or the trousers go on the top instead of the bottom, and so on. So that coordination ability, again, it's later on in the illness of dementia. Calculation I've talked about. Writing can be a difficulty, and reading can be a difficulty because if your short-term memory is poor, by the time you get to the bottom of the page, you can't remember what's been at the top of the page. So it can be very difficult to read. And another one that's very difficult for people with dementia, as I'm speaking about them, is television. Television is extraordinarily difficult for people with dementia because, again, if you think about watching anything on television, a soap or a movie or whatever, it changes every 30 seconds. You're in a different scene. Then you go back to the previous scene, from 2 minutes ago. If you can't remember what it was, it's very confusing, very confusing. And even the news. I was watching the news last night, and it changes very quickly. It's very hard to follow if you're not able to attend and remember. So, just a little bit about the coexistence of depression and dementia. Well, sometimes people with dementia will complain of feeling sad and feeling depressed or feeling unwell in themselves in that sense. Sometimes it's self-reported. Sometimes it's a relative will say, even with a diagnosis of dementia, they will say people have become more withdrawn, not as lively, not talking, not doing the things that they normally do. You can tell by observation, and sometimes in hospital we will see that. We can see people who are depressed. So the mood is anxious, sad, lack of reactivity, not being able to smile, laugh, react to the content of conversation. Maybe irritability, there may be agitation, there may be loss of interest, maybe an increase in physical complaints with no known cause, or retardation, and that's what that is a slowing of movement and speech, and not being able to react as quickly as normal. And then we can have poor appetite, weight loss, and poor energy. You can have mood can be worse in the morning. Typically, depression is worse in the morning and better in the evening in moderate to severe depression. You can have early morning wakening. Again, that's more typical of depression. And you can also have poor self-esteem, pessimism. Again, one has to think about suicidal ideation. And mood-congruent delusions. So delusions, as I mentioned, things like not having enough money, being guilty, loss, feelings of loss, and nihilism. So, finally, I get to the point, maybe, distinguishing characteristics of depression and dementia. These are two columns. The left is depression and the right is dementia. And you can see the differences between the two conditions. So for depression, it's usually, as I said, it's 2 weeks history, which is very short. 2 weeks is not long for depression. And again, it's sadness, loss of interest and pleasure. Whereas in dementia, it's more to do with that decline in cognitive ability, that mental processing ability, memory, language, communication, judgment perhaps. It could be on the depression side, it could be weeks to months, and often there may be a possible precipitant, but sometimes there isn't. And I'm often asked, certainly when somebody has recovered from a depressive episode, why did that happen? I didn't think of anything. I can't see why I would have got depressed. And sometimes it's not obvious why people get depressed. Sometimes it's a very obvious precipitant, and in older people it can often be a medical problem or a fall or an injury or a loss, a bereavement, something like that. With dementia, of course, it's a much longer onset, a gradual onset over months and years. Classically, depression has disturbed sleep with early morning wakening. In dementia, it's a variable sleep pattern, and there can be lots of difficulties with sleeping and people wandering at night, wandering during the daytime as well, but it's variable. It's not typically early morning wakening. Depressed mood, appetite changes. What else do we have here? I said that depression may not present with complaints of depressed mood. There may be increase in physical complaints, and there may be social withdrawal, people pulling back from seeing their friends, not doing the things they used to do, whatever that might be, group activities or seeing friends or going out for coffee or playing golf. With dementia, as I mentioned earlier, it's about 1 or 2 years before the diagnosis is made. I think there's a lot more recognition of it now, and I think people are much more readily prepared to come along if they've got a memory problem. I think when years gone by, people weren't so willing to present, but I think people do now, and we do have memory clinics all over the country where people come when they've got a complaint, they're worried about their memory, and they come along to have an assessment. I think it's vital. I think it's probably vital in both places that we get a collateral history, that we talk to a next of kin or a carer or somebody who knows the person well. So it's very typical in my service, anywhere I've ever worked with older people, that I would ask permission, of course, to get consent from the individual. But it really is very helpful to hear what somebody else has noticed is the change. What else is going on? What the issues are, and that would be very typical. I see the individual first, and then I would see somebody else from the family to find out what's happening, and that can often help with distinguishing the symptoms of what you're seeing. Again, more of what I've said about depression, I've discussed on the left-hand side, on the presentation of depression and the symptoms that people have, and then on the right are the symptoms with dementia. And you can see that the dementia symptoms are particularly around cognition, memory disturbance, language, abstraction, judgment, language difficulties. Sometimes you can get the persecutory delusions, and sometimes you get delusions or psychotic features in depression as well. So when we come to thinking about the management of people, what do we have to do? I think one thing I always have to, and what I tell all the trainees, you must keep your mind open at all times to what the possibilities might be. What could it be that you're seeing? You have to open your mind to think that it could be dementia, it could be depression, it could be the coexistence of the two, or it might be neither. It could be mild cognitive impairment, just a short-term memory loss, but that doesn't meet the criteria for dementia, and that could be a possibility. You need to do a thorough assessment, and that includes both from a psychiatric perspective, all the symptoms that are there, looking at, and I don't have time to talk about it here, but past psychiatric history, what medical problems there are, what family history there might be, medications, alcohol, background, a bit of background history, mental state examination, looking for those features that are significant for either depression or dementia. We need to investigate. So for people with depression, I remember early in my career when I was a young doctor, which was many years ago at this point, but a gentleman was referred into the hospital, which I will remain nameless, but not this, it wasn't this one, referred in with depression. And I took one look at him and I said, my goodness, he is so pale looking. He was about the colour of the sheet. And I did a full blood count, and his hemoglobin was 4, which is way below what it should be, and he was anemic. He wasn't depressed at all, but he had been sent into a hospital, so we have to investigate. We have to do all those routine blood tests to make sure that we're not missing anything medical. It's particularly concerning in older people that you must look at all those options. You might do a chest x-ray. You might look at neuroimaging. You might do a scan to see what changes there might be on a brain scan, an MRI scan, or a CT scan. You might admit somebody for observation if you wanted to just look in a bit more detail. You may treat somebody for their depressive illness and then assess cognition afterwards. So you may get somebody who's so depressed that they can't be bothered doing the memory test. Do you mind? I'm not going to do that. I'm not interested, or whatever. So you might just wait, treat the depression, reassess cognition afterwards, and see how they do. And things may have improved, or there may be problem left behind. How do we treat the depression? Well, there's lots of things we can do: antidepressants, psychotherapy, socialization, activity, putting supports in. There's lots of options. And then, of course, one can treat the dementia depending on what the cause is. There are many different treatments that are available and options that can be used to improve quality of life and lessen the difficulty. So just going back to my man at the beginning, he's an 80-year-old single man. He's a 2-month history as presented at the time. Social withdrawal, poor appetite with weight loss, self-neglect, presented with chest infection and confusion. Well, clearly there's just not enough information, so we need to go back, we need to see him in detail, we need to get all the information that I've described that we need to get. We need to get a collateral history from somebody who knows him well and can give a history as to what this man was like before and what's different now, and what has been the progress over a period of time. Has it been longer than 2 months? It could have been a year. Or is it just 2 months? Or is it just that perhaps he's had been bereaved 2 months ago and this is a depressive illness? And if he has withdrawn and he's not eating well and he's not looking after himself well, he might be prone to getting an infection. And maybe if you treated the infection, the confusion would clear, be left with depression, treat the depression. Or maybe it would clear and he's not depressed. So you need to look at it in a lot more detail. So I think that's about all I have to say at the moment, and I'd be very happy to take questions. Yes, thank you. And thank you for your attention.